Hi, I am Peter Glowicki, Editor-in-Chief of the Journal of Vascular Surgery, and I am also the Joe M. and Ruth Roberts Professor of Surgery of the Division of Vascular and Endovascular Surgery at Mayo Clinic in Rochester, Minnesota. Together with my new co-editor, Dr. Peter Lawrence from UCLA Medical School, we are excited to bring you our first issue of this prestigious journal, which is published with a new cover, a fully redesigned table of content, and also a new page design. We are eager to hear your opinion and comments on how you like the new format and also on how to improve the content of this journal. I am pleased to introduce you now the highlights of the July issue, including the editor's choice, the CME article, and two more outstanding papers. Dr. Fujimura and his colleagues from Dr. Ron Dahlman's research team at the Vascular Center of Stanford University addressed the observation of several population-based studies that diabetes mellitus has been negatively associated with the prevalence and progression of abdominal aortic aneurysm disease. These authors found that of 58 diabetic patients who had an abdominal aortic aneurysm, only metformin usage was negatively associated with aneurysm enlargement. This association remained significant even after controlling for gender, age, cigarette smoking status, and obesity. In an experimental model in mice, metformin dramatically suppressed the formation and progression of the aneurysms. The authors concluded that epidemiologic evidence of abdominal aortic aneurysm suppression in diabetes may be attributable to concurrent therapy with the oral hypoglycemic agent metformin. One of the highlights of the July issue is the CME article on conversion from EVAR to open abdominal aortic aneurysm repair. This paper was the result of an international collaboration written by Dr. Klaas and colleagues from Dr. Schermerhorn's group at Beth Israel Deaconess Medical Center and Harvard Medical School, Boston, Massachusetts, and Dr. Hans Verhagen's group from the Erasmus University Center in Rotterdam, the Netherlands. Now, this study assessed the outcome of patients undergoing a conversion after failed EVAR and compared outcomes to standard open aneurysm repair and to EVAR. The authors used data of the National Surgical Quality Improvement Program, NSQIP database. Over 32,000 patients were included in this study, and 300 of them had conversion to open repair. And conversion to open repair had a 10% 30-day mortality that was significantly higher than mortality after elective open repair, 4.2%, or mortality after EVAR, 1.7%. Conversion had the highest rate of complications. Factors associated with conversion included large diameter of the aneurysm, young age, female gender, and non-white race. These authors concluded that conversion to open repair after failed EVAR is associated with substantially increased perioperative morbidity and mortality compared to standard aneurysm repair. This is another reason why patients who undergo EVAR must be carefully selected. Another highlight of the July issue comes from the CREST study investigators, headed by Thomas Brott at Mayo Clinic in Jacksonville, Florida. Dr. Hai and colleagues studied the association of anesthesia type and periprocedural myocardial infarction among patients who had surgery or stent in the CREST trial. Of the 111 patients who had carotid endarterectomy with regional anesthesia, the incidence of myocardial infarction was 1.8% in the CE group and 1.7% in the stent group. In contrast, the incidence of myocardial infarction was the highest 3.4% among patients who had endarterectomy in general anesthesia. And this was significantly higher than the risk of myocardial infarction in those patients who undergo stenting or who had endarterectomy in regional anesthesia. So this study concluded that regional anesthesia should be seriously considered for patients who undergo open endarterectomy. Finally, another highlight of this issue also deals with drivers of readmissions in vascular surgery patients. Dr. Glebova and colleagues from the University of Colorado and from the Johns Hopkins Medical Institute in Baltimore, Maryland studied multiple potential drivers of readmission and created a model for predicting the risk of readmission in vascular patients. Using the American College of Surgeons National Quality Improvement Program dataset, these authors found an unplanned readmission rate of 9.3%. Predictors of readmission were post-discharge deep space infection, superficial surgical site infection, pneumonia, myocardial infarction, and sepsis. This study concluded that readmissions in vascular surgery patients are mainly driven by postoperative complications identified after discharge. Thus, efforts to reduce vascular readmissions should probably focus on prompt identification of modifiable post-discharge complications. These were just a few of the many great articles from our July issue. To access these articles free in the entire month of July, please visit us on www.jvascsurg.org. Enjoy our first issue, and please remember to send us your comments and suggestions. Thank you for viewing, and see you again next time for highlights of the August issue of the Journal of Vascular Surgery.